Bismillahirrahmanirrahim. As Allah subhanahu wa ta'ala has made women different from men, so obviously there is difference in pathophysiology of ischemic heart disease in women as compared to men. So the topic given to me is guidelines for the heart failure in women. So how we define heart failure, that is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. So previously, as Ma'am Nusrat and Ma'am Amber has delineated it beautifully, the differences. Again, I highlight these differences of women with heart failure as compared to men. That women tend to develop congestive heart failure at an older age than men. And women tend to develop diastolic heart failure with a more normal ejection fraction than men. That is, they develop diastolic heart failure more than men.
You were the chairperson.
And then, as delineated previously, depression is frequently associated with heart failure and is more common in women than men. And this point has been elaborated by Ma'am Amber, that is very in detail. Again, peripartum cardiomyopathy. This is a cause of heart failure unique to women. And this peripartum cardiomyopathy occurs without an identifiable cause. Although the signs and symptoms of heart failure are the same among men and women, but women tend to have more symptoms such as shortness of breath and more difficulty in exercising than men. And in general, women survive longer than men with heart failure. So what causes are unique of heart failure in women? The topmost cause is hypertension. Hypertension it raises the risk of heart failure 2 to 3 times more in women as compared to men. And second comes the valvular heart disease. In our social setup, women tend to have more rheumatic heart disease, especially mitral stenosis and mitral regurgitation. And they come very late to the hospital. So mostly the women, they have heart failure when they present to the hospital. And then comes the diabetes mellitus. It does not cause heart failure directly, but it promotes coronary artery disease and hypertension, especially in women. Ischemic cardiomyopathy, it is less in women as compared to men. But certain forms of chemotherapy, for example, anthracyclines, that is doxorubicin, in women who are treated for breast cancer. And then again, peripartum cardiomyopathy, obviously in women. And then comes obesity. That is, obese women can have up to 50% greater risk of heart failure than men with a normal weight. And then severe lung disease leading to copper-pulmonale. Now we come to the management of the heart failure. According to the guidelines in 2022, stages of the heart failure has been redefined. That is, stage A is the patients for heart failure but without symptoms. And they are at risk of heart failure. And stage B is called as pre-heart failure. That is, no symptoms or signs of heart failure and have evidence of one of the following, that is structural heart disease, valvular heart disease, and then evidence of increasing filling pressure by invasive and non-invasive methods, and patients with risk factors like increased levels of BNP. And then comes stage C, that is symptomatic heart failure. This is with structural heart disease with current or previous symptoms of heart failure, and then stage D, that is advanced heart failure, with marked heart failure symptoms that interfere with daily life and with recurrent hospitalizations despite attempts to guideline-directed medical therapy. And this is the new classification of the heart failure, that is heart failure with reduced ejection fraction, with EF less than or equal to 40%, and then heart failure with mildly reduced ejection fraction, with ejection fraction 41 to 49%, and then heart failure with preserved ejection fraction, that is more than 50%. And when we treat these patients, we again reclassify them after serial assessments. That is, heart failure with reduced ejection fraction can progress into heart failure with reduced, again, less than 40%, or it can improve more than 40%. And then mildly reduced, that again go into less than 40%, or with mildly reduced, it may remain into mildly reduced, or it can improve. And heart failure with preserved ejection fraction, that may remain into heart failure with preserved ejection fraction, or it can progress to with mildly reduced or with reduced ejection fraction. And this is the brief algorithm to diagnose the heart failure or suspected heart failure, like biomarkers and transthoracic echocardiography. And guideline-directed medical therapy includes 4 medication classes. That is renin-angiotensin system inhibition with angiotensin receptor neprilysin inhibitors, that is ARNI, angiotensin converting enzyme inhibitors, or angiotensin 2 receptor blockers alone. Second is beta blockers. Third is mineralocorticoid receptor antagonists. And the new group is sodium glucose cotransporter 2 inhibitors. That is added in heart failure therapy now. And these are the recommendations of sodium glucose cotransporter 2 inhibitors in heart failure. In stage A, that is at risk of heart failure, the recommendation is class 1 to prevent heart failure hospitalizations in patients with type 2 diabetes who have cardiovascular disease or at high risk for cardiovascular disease. So this is class 1 recommendation now. And in stage C, that is symptomatic heart failure, again with reduced ejection fraction. Again, it is class 1 recommendation to reduce heart failure hospitalization and cardiovascular mortality in patients with symptomatic chronic heart failure with reduced ejection fraction. And please note, this is regardless of the presence of type 2 diabetes mellitus. So this is now recommended as class 1. And heart failure with preserved ejection fraction, it is recommended as class 2A to reduce heart failure hospitalizations and cardiovascular mortality in patients with heart failure with preserved ejection fraction, and again in heart failure with mildly reduced ejection fraction. And these guidelines were based upon these trials. That was Canvas, Declare, TIMI 58, AMPA outcome. That trials were with patients who had type 2 diabetes, and in stage C, the symptomatic patients with reduced heart failure, irrespective of presence of type 2 diabetes. And these trials were defined heart failure, DAPA heart failure, and AMPA reduced trials. And this is the algorithm, that is heart failure with reduced ejection fraction that is less than 40%. And as you can all see that all the drugs are class 1 recommendation. And if these patients, they are medically treated heart failure, then they can go into ICD, CRTD, or consider additional therapies. And then again, if refractory heart failure in stage D, we can offer them a mechanical circulatory support like artificial heart, cardiac transplant, and palliative care. And how we treat symptomatic heart failure with mildly reduced ejection fraction. Again, all these are class 1 2A recommendations, but diuretics are class 1 recommendation. And this is symptomatic heart failure with preserved ejection fraction. Again, diuretics are class 1, while sodium glucose cotransporter 2 inhibitors are 2A recommendation. And these are additional therapies in patients with heart failure and comorbidities. Like hypertension, treat hypertension. If the diabetes, treat diabetes. If the patient has suitable coronary anatomy, go for surgical revascularization. If there is patients with heart failure and valvular heart disease or cancer therapy, then multidisciplinary management should be done. And if the patients have heart failure and atrial fibrillation, then go for anticoagulation therapy too. And then if the patients with heart failure have iron deficiency, iron replacement therapy should be given with atrial fibrillation and ejection fraction less than 50%. Then go for AV nodal ablation and CRT implantation. Patients with heart failure and symptoms attributable to atrial fibrillation, then go for atrial fibrillation ablation. And then obstructive sleep apnea syndrome, go for CPAP. And in asymptomatic patients with cancer therapy related cardiomyopathy, then ARBs, ACE inhibitors, and beta blocker, that is medical therapy. So due to their unique pathophysiology and etiology differences in cardiovascular physiology and neurohormonal mechanisms and metabolism, women need to be more appropriately presented in research studies. Females on average constitute less than 25% of the enrolled patients. And guideline-directed medical therapy show no differences in overall recommendations for standard medical therapy between men and women. The main contraindications for using ACE inhibitors, ARBs, and neprilysin inhibitors in females is pregnancy due to the risk of birth defects associated with these drug classes. Multiple studies evaluate the role of beta blockers in patients with heart failure that shows beneficial results for survival and heart failure hospitalization in women. And like these mineralocorticoid receptor antagonists are also beneficial in men as shown in RAILS and AFIC studies. And in AHIF study, the combination drug hydralazine and isosorbate was shown to improve survival in both men and women. CRT in studies with female representation, there was evidence of a few deaths or hospitalization in women with CRT. And ICD therapy can prevent death and is recommended in women as in men. Mechanical circulatory devices that are used as a bridge to transplant they can be used as a destination therapy for both male and female patients. Heart transplant is associated with similar survival rates in both men and women. So my last slide is that the key point is heart failure is an important cause of morbidity and mortality in women, and women tend to develop heart failure at a later age than men. Heart failure with preserved ejection fraction is more common in women than in men and accounts for at least half the cases of heart failure in men. But overall recommendations for guideline-directed medical therapy show no difference in treatment approaches between men and women. However, women are generally underrepresented in clinical trials for heart failure. And further studies are needed to shed light on the different mechanisms, causes, and targeted therapies for heart failure in women. Thank you very much.